Rahim. Today I'm going to talk about the important point in the ventilator adjustment, which is the triggering. Triggering is, as we have mentioned before, the change from expiration to inspirations. And this might be time, flow, or pressure. Time triggering, this is usually in the controlled mandated ventilation when the patient is paralyzed. So this is it will be time when you set the rate 15 press per minute. So every 4 seconds, this the ventilator will start to deliver his press. But this is a flow and pressure. Usually the pressure is about 3 centimeter water. When the patient makes an effort, negative pressures by 3 centimeter water, so the demand valve will respond by opening and delivering the pressure to the patient. If the patient made an effort which is 2 centimeter water instead of 3 centimeter water as the triggering value you set for the ventilator will not respond because it does not come up to the level. Same thing for the flow. If you set the flow 3 liter per minute and the patient made flow, negative flow by 3 liter per minute, so the demand valve will open and deliver the press. This is the flow. Usually we say flow by system. This is the continuous on at the expirations. The demand valve does not close completely, but there is a basal flow, what's called basal flow, and this basal flow is present in the during the expiratory pulse. So I say if the basal flow is 10 liter per minute, so it will be delivered from the inspiratory from the demand valve and they'll go to the exhalation valve. So this is the exhalation valve is now is a sensitive one. When the patient starts to take his breaths, so he takes some of this flow, and so the remaining flow will be less than that which is delivered from the inhalation valve. So the exhalation valve will sense that the patient start to take his breaths. That's why the demand valve open and deliver this the preset flow. This is a very important one because it is associated with less effort by the patients. At the same time, this basal flow is responsible for decreasing or overcoming the endotracheal tube or tracheostomy tube resistance, and this is very important in the basal flow. This is just regarding the basal flow. Triggering is important for the patient to be synchronized with the machine. At the same time, the value is important. If the value is within the normal, within the certain value, which is sufficient, which is where the patient can do it without more effort, like 2 to 3 centimeter water for the pressure or 3 liter per minute. For the flow, this means that the patient can do this job and the demand valve will open. If it is less than this, this will be associated what we call auto triggering. If it is more, so the patient has to do more effort and sometimes maybe associated with non-triggering. Let's go and see what are the problem for the triggering. The triggering, there is a problem of tachypnea, peridipnea, auto triggering, non-triggering, and double triggering. Let us go and see and talk about each of them separately. The tachypnea and the bradypnea, this means that the patient is doing an effort, which with each effort there is a response from the ventilator. If the patient is taking his breath at 20 breaths per minute, the ventilator is delivering it because the patient is making an effort sufficient to open the demand valve. The patient increases his respiratory rate instead of 20 to 30, 35. This means the machine is responding because the patient is making an effort. But take care of this when you are dealing with the cabinet patients. Important. The cabinet may be due to stimulation of coming firing from the respiratory centers due to being because the respiratory center is being stimulated by the chemoreceptors or mechanoreceptors or from the central or sometimes psychogenic. These are the mechanism which is responsible for the kidney. The kidney chemoreceptors, which is increase in hydrogen ion, carbon dioxide, or decrease in the oxygens. Whether this chemoreceptors peripheral or central chemoreceptors. Tachypnea due to metabolic acidosis, by the way. This is usually compensatory, and sometimes you put the patient for metabolic acidosis on the ventilator till you make a dialysis for the patient, so to correct him. Otherwise, the patient will develop respiratory failure from exhaustion, and he will, in this case, add respiratory acidosis in addition to metabolic acidosis, which may lead to cardiac arrest to the patient. So you put the patient on the ventilator, and at the same time, you do the job instead of the respiratory pump in order to avoid failure of respiratory pump. In this case, you have to increase the minute volume in order to wash out carbon dioxide in order to keep the pH close to the normal till you treat the underlying cause. So this is one of the mechanisms. Sometimes the carbon dioxide, increasing the carbon dioxide as failure to adjust the ventilator. In this case, the minute volume is below normal. That's why these carbon dioxide corrections retention. In this case, you have to increase the tidal volume and in order to increase the minute volume. And by the way, the respiratory rate will decrease and the patient, and so you can correct the tachypnea by this way. If the patient is hypoxic, you have to increase the FiO2 or make some sort of recruitment or position, something like that, for the correction of the oxygen. In this case, the tachypnea will decrease. Another important point, sometimes the patient is normoxic, normocapnic, something like that, but the patient is still tachypnea due to the stretch receptor. The stretch receptor in the lung, as in case of pneumonia. The patient is pneumonic, but the pH is normal, the oxygen is normal, but there's wash out carbon dioxide due to the presence of stretch receptor. So sedation in this case will be important. Another important point, which is the irritating receptors. Increasing the flow, as I've mentioned before, will be associated with tachypnea. You have to adjust the flow in order to adjust the tachypnea. Pain sometimes is associated with tachypnea, and in this case, you have to give some sort of analgesia or sedation to the patient. So the second, or the another important point for the kidney, which is central, and this may be the Chinese socket aspirations. This is maybe, or sometimes is the patient with head trauma is developing severe tachypnea. In this case, you have to give the patient sedation, so we put him on ventilators and martial relaxant or heavy sedations because these tachypnea will be associated with wash out of carbon dioxide and the resulting into cerebrovascular constrictions, and the patient might kill himself. In this case, you have to put the patient on ventilator and adjust the carbon dioxide or adjust the minute volume to keep the carbon dioxide around 30, 35 in order to protect the brain. And another important point for this is the tachypnea. When you put when there's tachypnea, sometimes it's difficult to control the patients. Keep an eye. Don't put the patients on volume controlled ventilation. Otherwise, the patients will develop dynamic hyperventilations and pneumothorax. If you put the patients on pressure control, so it is a little bit safe. The problem is there is no pneumothorax, but you may face a problem of hypoventilation so and carbon dioxide retention. But this is more better than putting the patients on volume controlled, and the patient will develop dynamic hyperinflations developing pneumothorax. Bradyapnea is usually due to drug or something or analgesia or heavy analgesia or something like that. You have to do to see the cause of bradyapnea, and in this case, you have to treat accordingly. This is a case. This is pictures of patients in tachypnea. The third part, which is auto triggering. What's meant by auto triggering? Auto triggering that this means that the patient himself did not stimulate the ventilator to start a cycle, but it is this simulation is outside, usually from the patient circuit. The patient did not make an effort to trigger the ventilator, but this triggering is outside from the patient circuit. And patient circuit, this usually due to the cardiac oscillations might lead to something like that. High sensitivity setting, instead of being 3 centimeter water, you put 1 centimeter water. This way, that's why the demand valve becomes very sensitive to any change or to any change in the pressures or oscillations in the patient circuit, which might be some sort of leak from the circuit, intratracheal cuff leak or chest tube cuff leak, or the presence of water condensation in the circuits. So to avoid the auto triggering, you have to take care of this. This is the circuit should be intact, no water condensations, no secretions, no leak, and the sensitivity should be adjusted, not to be low, but within the accepted level, which is about 2 or 3 centimeter water or 3 liter per minute. That's it. The fourth one, which is non-triggering. This is an effort done by the patients, but does not come up to stimulate the demand valve to open the demand valve. Say this means that if you put the demand valve on 3 centimeter water, the patient in this case will never be able to develop 3 centimeter water. Well, you can develop 1 centimeter water or 2 centimeter water, and for sure this will not open the demand valve because the demand valve has been set to a certain value, and this the patient didn't reach to this settlement. What are the causes? You have to look for the causes. Number one, maybe the drive of the patient. The drive of the patient which is defining from the respiratory centers. In this case, it is low. Maybe just as in cases of patients with COPD, the drive the patient in this case might be low, or the patient with high, as I've mentioned before, that the increase in the tidal volume will be associated with decrease in the drive. So this is another point. Take care of the high tidal volume may be associated with decrease in the drive, and accordingly, one drive or one drive may be sufficient to stimulate, and the other drive will not be sufficient to stimulate. Another important point, which is decrease in the muscle power due to cachexia, due to wasting, and this is common if the patient stayed on the ventilator for long times, and there is failure of nutritional support or the failure to antagonize the effect of the oxidative stress and something like that. Third part, which is intrinsic beam. The patient, in order to trigger, he has to neutralize the value of the intrinsic beam, what is it is 5, 7, something like that, in addition to the value of the triggering value. So the patient has to make a large effort. So this may be a cause of failure to trigger or not triggering. Or you yourself you set triggering value, high triggering value, instead of 3 it is 5, something like that. This will exhaust the patient. At the same time will not be sufficient, not all the triggering value will reach to this value. The last one, which is the utilization of nebulizer. Well, this will make some sort of flow, and this will disturb the base of flow, and in this case you have to change and from flow triggering into pressure triggering. That's it. This is and this is this triggering value. This is non-effective one. This is large but non-effective. This large but effective. This is one which is effective, which meets the preset trigger value on the machine. This is intrinsic beef. The patient has to overcome this. You have to neutralize this, and in addition to this, he has to add the preset value. So in this case, if there is some sort of intrinsic beef, you have to put the extrinsic beef about 80 to 85% of the intrinsic beef. So the patient has to make this small effort in addition to the triggering value. So the value, so the effort of the patient will be smaller, but this is the effort is larger. So not all the triggering value of the patients will be sufficient to trigger the presence of auto beep. But if you put an extrinsic beep, about 80% of the intrinsic beep, in this case, the remaining part will be small, and in this case, the patient will be able to make some sort of triggering, and the non-triggering will not be present. Another important character in the case of volume controlled ventilations, the volume controlled ventilations, this is the ventilator itself is preset, there's preset flow and preset tidal volume. Whenever it is stimulated, the demand valve will open, and the ventilator does not by any means respond to the patients. So if the patient is taking his inspirations, again another inspiration during the flow, the ventilator will not respond. No, and at the same time, if the patient start to cough or do it, the ventilator will not respond. And if the triggering value is below the preset value, the ventilator will not respond. But I'm just here, the patient, even the patient effort, if the patient just the effort done by the patient to trigger, This is if the patient, this will trigger if the patient is making more effort. This not will not add to the tidal volume, but it is a preset tidal volume. It will not increase the tidal volume, and even it will not increase the flow. So this is just triggering, and after that the machine will deliver the preset tidal volume and the preset flow. No change in the tidal volume, no change in the flow, and even if the patient is had made any effort here, this will not has any response regarding the flow or the volume. Here, how can you detect the most common things for non-triggering is two things. The preset value may be large or the intrinsic may be present. How can you detect this? This is usually has been declared by Magdi Yunus symposium in March 2003. So he mentioned this is look at this. This is and the pragmatic pressure or visual pressure you can trace the drive of the patients and the effort done by the patients by these diaphragmatic pressure or the esophageal manometer, the esophageal pressure. So this is a drive of the patients, another drive. Look at this. This is associated with opening of the demand valve. This is a failure of this to trigger. This is one. Then triggering. This is failure to trigger. This one triggered, and this is failure to trigger. So look at this. So this is the number. If you look at this, this is the triggering value by the patients. Here, the response of the machine is about half the triggering value of the patients. So here we can study it. Look at this. This is the patient started to make an effort, and this started here. The response here started the response of the machine to deliver to deliver the breast to the patient at this value. So this is one. But when you look at this, the patient here made an effort, and the maximum effort of the patient at the maximum effort, the machine started to respond. This means that this is the value, which is the triggering value, which is the demand valve responded. But when you come to here, the patient reached to its maximum, but this maximum effort was not sufficient to trigger. This way, no triggering. So this is a non-triggering value. The value of this was not sufficient to trigger. Uh, look. Yeah, Dr. Yunus mentioned that this patient had the respiratory rate was good, and patient support was 15. When he started to wean the patients and came with the patient support instead of 15 to 12, the patient started to be tachypneic. But he observed here that the diaphragmatic pressure or the gel pressure here, this is when you look at it, the patient is tachypneic. But here on the number of respiratory rate here on the ventilator for the triggered number, it is nearly half this. And when we look at the pressure time curve or the flow time curve or volume time curve, it is good. The rate is good, but the esophageal is high. This means that the patient has the tidal volume is large, so there is some sort of inhibitions or decrease in the drive of the patient. That's why not all the driving waves were sufficient to trigger. That's why when the pressure support decreased from 15 to 12, this means that the tidal volume will decrease, and accordingly the driving pressure of the patients will increase, and therefore every drive here has been associated with triggering, so the patient became tachypneic. So to take care of this when you are dealing with the patients, when you come down with them, so this means that there should be some pathology, some problem with the patient, how to solve the problem before you wean the patient off the ventilator. So this is you can trace this problem by following the flow time curve. At the first deflection, this is the second deflection. So this is the one which is responsible for the intrinsic beam, and this is for the value of the triggering value. So this is intrinsic beep. This trigger value is small, but the intrinsic beep is large. When you look at this, no intrinsic beep, this is the trigger value is large. When you like so this is regarding the how can you detect the problem of intrinsic beep and the trigger value. The last one I think, which is the double triggering. Double triggering, this means that this is defined as two ventilator insufflations delivered within one patient inspiratory effort. The patient during his one inspiratory effort, the ventilator delivers two insufflations. That's why this is usually the most common problem for this, that the patient inspiratory cycle is larger than the ventilator inspiratory cycle. And this means that short inspiratory time, and this usually comes when the inspiratory time of the patient is large, or this due to hypoxia, the patient takes inspiratory time will be large, or maximum inspiratory pressures, the inspiratory time would be large, high PEEP make it large, and at the same time the expiratory triggering sensitivity and the patient support it as just to be low for the ventilator. Look at this is important one. When you look at if the patient, this is a ventilator in inspiratory time, and inspiratory time is shorter than the patient in inspiratory time. This means that the demand valve opened and the demand valve closed, and the ventilator starts to go in expiration, but still the patient in inspiration. So the patient stimulates again the demand valve to deliver another breath, another cycle. So the cycle will come here, and there is no expiratory pause. So this is the most important point, that the patient time is larger than the ventilator time. The ventilator, this patient time, so you have to adjust the ventilator time. If it is pressure support, you have to adjust either to increase the pressure support or to adjust the expiratory sensitivity in order to come to be close to the patient. Or in the case of pressure control, you have to adjust it to adjust the inspiratory time of the ventilator to be the same like the patient, and this can be adjusted by observing the pressure time curve, the end of the pressure time curve, with overshooting or smooth or something like that. So this is an important one. This is the double cycling or double triggering in pressure controlled ventilation, and this is a double triggering and a volume controlled ventilations, and this is the problem you should take care by adjusting. So this is a pressure support ventilations. In this case, you have to increase the inspector time of the ventilator instead of being 75 to 50 or 30 or 20. So this means that you are increasing the inspector time of the ventilator. By increasing the inspector time of the ventilator, so to match the inspector time of the patient, at the same time the tidal volume will be delivered by the machine will be increased. So this is about for the pressure controlled. This is you in the pressure controlled ventilations, you set, there is a preset for the pressure and the preset for the inspector time. You have to increase the inspector time for some to match that of the patient, and in this case you will solve the problem for the patient. That's it. This is a double triggering, and this is double triggering because the ventilator inspector time is shorter than that in the patient inspector time. As I have mentioned before, you have to increase the inspector time of the ventilator, either pressure controlled or pressure support, by decreasing the expression sensitivity, instead of 30 to be 20, something like that, to increase that, or increasing the pressure and the pressure support ventilation to increase the time. So this is in this case the double triggering will not happen, and in this case the tidal volume in this double triggering is small. If it is not like that, if you correct it, the tidal volume will increase, and the synchrony with the patient will be abolished, and the patient will match. They will be matching in time regarding the ventilator and the patient. Thank you.